Thank you. So let's give it a couple of more minutes to see if we'll have additional attendance. Can you guys see me okay, or is it dark?
It's a bit dark.
Yeah, that's what I was gonna say. It's we see more of the light from your window behind you. That's better.
That's better.
Okay. Yeah, I was just trying to get this where more light will come in.
You had that good Bond villain look there for a second, all in shadow and the light behind you. Yeah.
Okay,
Well, I'm not saying that you would be, but if you had a cat on your lap right now.
All right. Well, that's better.
Yes, you're now nicely visible.
Okay, and also being recorded too. So, okay, well, Oliver, I guess I'll just start. So, since the recording is already up and going, I just want to say hello, everyone, and welcome to our 5th meeting. My name is Glendora Claybrooks, and I am the chair of the Consumer Advisory Committee and a task force member. At this time, I will ask the vice chair to introduce himself.
John Santa here. Nice to be meeting today.
Okay, thank you, John. So I'll just briefly give you an overcap of the discussion items on our agenda. We will first our agenda, the first thing on our agenda, other than introduction, is the roll call. So after the roll call, we will review and approve the summarization from our January 11th meeting. Then the staff will provide an update on task force timeline and the requested extension around Senate Bill 428. The next item will be addressing the questions, the first of which deals with the type of taxes that the CAC thinks should be used to fund a single-payer universal health care plan. And question number 2 will revolve around your perceptions of high-value care. Then we will allow for CAC members to have an open discussion on any desired topics of interest around or to present to the tags and task force. Then we will discuss the interactions of the task force and CAC meeting process. Following that, we'll have a 10 minutes for public comments. And lastly, we'll discuss next steps. So I do not see Brian. So Oliver, are you going to be the presenter for roll call?
Yes, Glendora, that's me today.
Thank you. Will you please?
Yes, and I apologize if I don't pronounce your name correctly. We have Chelsea Alionar. Crispine Bala, Jules Garza. And if you would just say if you're in the meeting or not. Tori Getter, Ishmael Warsami, Di Tran.
Here.
Thank you. Colleen Nelson.
Present.
Thank you. Craig Sotolano,
Present.
Ada Kilsaw, Lori Hagland, Ellen Greenlaw, Ron Green.
Hi, just made it.
Great, thank you, Ron. Kevin Fitz, Vice Chair Santa,
Here.
and Chair Glaybrooks.
Here. Thank you, Oliver. Before we begin, I will just share with you the definition of high-value care as defined in the 2013 Institute of Medicine report. And that states that the best care for the patient with the optimal result for the circumstances delivered at the right price. So based on that, I'd be happy to repeat this definition at any time during our discussion at your request. So the question for each of you, I think I'll just give you the review of the January 11th meeting before I get into your questions. Okay, I just, at our January 11th meeting, we discussed the engagement process based on the principle of engagement, which included diversity, as well as geographics, because this indicated that this was indicated as one of your strongest strengths in which to provide input to the task force or tags. So we had 3 questions of engagement. Tag question number 1 revolved around affordable healthcare definitions. Do you have that summary from January 11th, Oliver? You can put that up. Yep, thanks.
You're welcome.
Okay, so can you guys, can everybody see this? Can't hear.
Yes,
Okay,
I can.
is there anybody who
Yes,
cannot?
can see it as well.
Okay. All right, so just follow along with me here. I'm talking about just went away, just disappeared like magic. Can we bring it back, Doc Oliver?
1 second, that was not intentional. Let's see. Hopefully that is now showing again.
Yeah. Okay, I'm gonna reduce it because it's in my screen. It can't see the whole document. Okay, so the engagement from the CAC members included 3 questions. revolving around the affordable healthcare definitions. So question number 1 to the committee members were, based on your lived experiences, how do you define affordable healthcare? And why do you define it this way? Okay, and can you scroll down to the considerations? All right. So you guys defined affordable healthcare, affordability as being included in all costs such as premiums, deductibles, and cost sharing. And also affordability should not be dependent on individual circumstances, including the specific health care needs. In addition, you said access to health care is a right, and a person's healthcare choices should not be limited to their financial situations. And the affordable healthcare should vary according to a person's ability to pay. For example, reasonable percentage of income. So question number 2 was about decoupling employment and insurance coverage. So it reads, how do you feel about decoupling health insurance coverage from employment? What do you think about the separation between these two systems of practices? And what are the pros and cons of separating the two? You answered that healthcare insurance coverage was burdensome and costly and complicated bargaining for the employers. And also that you thought current coupling of employment and insurance could lock people into their jobs just to keep their healthcare coverage. And question number 3 asks the following. In the development of a universal healthcare design plan, excuse me, what participation options to join the plan do you believe are necessary to meet the public health and the healthcare consumers' needs? A mandatory or voluntary participation option? And why is your option important or not important to you? And which of these options would you recommend to the TAG and or task force? And you answered that mandatory participation could help ensure costs are shared equally by everyone, and that equitable access to the healthcare is a moral principle. And this will prevent multiple tiered systems from incentivizing providers to prefer those coverages that provide the most reimbursement. And also that it was important to differentiate between mandatory participation in the systems and mandatory receipt of the services. So the recommendations to the task force were to consider accessing healthcare and that it not depend on individual circumstances, including their health status, employment, or income. And financial support of the system should be equally distributed and should not harm but benefit every individual based on the financial resources. And that decoupling access to healthcare from employment was an important in ensuring an equitable access. Lastly, when discussing the participation system, it's important to note that the language is essential as well. such that mandated participation can be perceived as requirements about receipt of services. So that is the overview caption of our January 11th meeting, and information you provided to be relayed to the tags and task force. Okay, I'm done with that, Oliver. So now we will go to the third item on the agenda, which is about the task force timeline. And I will now turn it over to Oliver to discuss the SB 428. Following that will be the vice chair and his engagement with you on type of taxes. Thanks. You,
Great.
Oliver.
Great. Good afternoon, everyone. Thank you for being here today. Might not be as familiar with me as you are with my counterpart, Brian Ebert. So I appreciate Chair Glendora and Vice Chair Santa having another committee staffer here this afternoon. Hopefully everyone's doing well. We had a little bit of sun over the weekend. Hopefully some of you were able to get outdoors. I do want to acknowledge that the February 15th meeting was canceled, as everyone knows, and we appreciate your understanding with the power outages that was happening during that snow and ice storm in the state. We were not able to hold the meeting, so I'm glad we're here today. So a couple of the agenda items, as Chair Claybrooks has already shared, are kind of follow-ups. So what I wanted to do is just spend maybe 5 minutes and give you an update of where the task force is at. Obviously, the Consumer Advisory Committee is one of a number of entities that are working feverishly to provide contributing to a lot of hard work to informing the task force as outlined in Senate Bill 770. So I'll walk you through the timeline of where the task force is at now, and then we'll move on and talk about Senator Manning, who is one of the chief sponsors of Senate Bill 770. He does have a piece of legislation that was introduced in this legislative session, did get a public hearing and work session and moved out of Senate Healthcare and is now sitting in Ways and Means, and we'll talk about what that potential extension might look like. So here, this is a busy slide. So let me just stop here and let everyone just have a minute to kind of take a look at it. For those who are not part of the CAC, but are members of the public who are listening and observing the meeting on Zoom, the slide deck is posted under the OHA task force materials page. So you will see this slide deck there. So what this is showing is a number of the plan design elements that the task force has been working on, largely through the technical advisory groups. And 2 of those groups have completed their work for the most part. The Eligibility, Benefits, and Affordability Technical Advisory Group, or TAG for short. They've wrapped up their work, and they are coming back and bringing their recommendations actually this month to the task force for the task force to consider a body of recommendations. The Provider Participation and Reimbursement TAG has wrapped up and has moved forward. And then the 2 other ones that are still working very diligently is the Finance and Revenue. So thinking about what that cost structure, what are those revenue sources to fund a universal system of coverage per the bill. They continue to meet, and they will probably meet in through April and bring back their final recommendations to the task force in April. And then the final and 4th tag around governance is scheduled to start actually in about a week. So that'll be the 4th and final technical advisory group that'll be meeting. But hopefully this timeline can give you an idea of kind of every month where some of the specific elements related to the overall task force and its work will be completed. Obviously, it's a little bit fluid. Some of the schedules, some things, I won't say get completed earlier. This is such a complex endeavor. Things have taken sometimes a little bit more than a month than when we initially scheduled it, but at least this gives you an idea. But ultimately, the task force is scheduled to wrap up its work and have a draft report hopefully by May, but certainly by June. The task force is required by the Senate Bill 770 to complete its report and the recommendations that they can get through and send those to the legislature in June. So let me stop here and see if members have a question about the overall timeline and anything that kind of comes to mind looking and hearing me kind of walk through the current body of work underway in the task force. Okay.
Hello?
Yes.
Yes. This is Ada and Oliver, and I just wanted to
Ada.
give you some input on this design that you have here, which is, it's quite a bit to look at. But I just wanted to give input with the CACs, the meetings that we've had, the input we've tried to make to the task force. My concern is the amount of information that we're able to give input to a recommendation for the task force as they're, developing their recommendations through the tag. Okay. I know that there's a summary you receive. You guys can, the staff can look at our meetings, but I'm finding that, throughout this crisis that we're working through, it's been very overwhelming. It's at a high level, even with the tags, trying to follow all the information on top of the task force meetings and then trying to keep up with our own meetings has been very difficult.
Yes.
In conjunction along with the technical difficulties on the computers that we've had, and also the loss of time through the snow. Okay. So it's just overwhelming. I just wanted to give you some input on that. And what I was really hoping out of this for the CAC is for us to have more collaboration and engagement with the community on a lot of these issues. There's a real issue of time constraints that we've had to deal with. And because of those time constraints, and I'm just speaking personally myself, I'm not feeling comfortable with, what we have done thus far. We've given some good input, but I was really looking at a more engaged approach with the communities because there's so much going on out there, including through the legislation and including with the COVID, with this universal health, and then trying to reach individuals and to get information in a timely process has been very difficult. So to spend I don't know, half an hour, or maybe even, just to go through each individual, of our committee to give input, it can be a little cumbersome, depending upon what's happening with everyone. And then also what we have no control over, during the meetings, whether it's through the weather or the COVID or the technical problems. So I just wanted to
this
put
is
that out there.
Glenn. This is Glenn. Let me just stop for a minute and ask Oliver if this is a conversation that we can take up in the open discussion session, or is this something, Oliver, you would like to address and find pertinent to the design plan?
Yeah. So thank you, Chair Glaberts. I mean, I think, Ada, you're giving voice to a number of issues that I think you're clearly not alone in. One, and just some of the challenges of keeping up with just the volume of information, the number of meetings, and just the sheer content of stuff that's coming out of the technical advisory groups as well as the task force. I want to acknowledge that. And I also want to acknowledge just the challenges of the meeting technologies. And I think this has not been ideal for a lot of us meeting in this format online. So I definitely appreciate you sharing those concerns, and I will defer how you want to have, when you want to have this conversation, Chair Claybrooks, if you want to do it now, or if you want to do it in the open session, I'll defer to you and your vice chair. But it's helpful just at least hear kind of some of the general feedback that I'm hearing this evening.
Thank you.
Aida. Great points. And I think we'll have more time to elaborate on those issues in the open discussion. So we will proceed with the agenda, and that is to open it up to the vice chair to engage you guys in the tax conversation topic. Is that okay, Aida?
Yes, that's fine.
Okay, thanks.
Oliver, were you done?
I had a couple more slides, but if Glendora, if you want me to just jump ahead, please go ahead.
No, I'm sorry, Oliver. I'd like for you to finish. It's still your time.
So you're all dime at time. I'm here to be as helpful as I can as your all staff. So let me just, you'll see again, this is a little bit different slice of information from the last slide. It just shows you what is coming to the task force in each month. In terms of this month, you can see, sorry for the shorthand, that might not be helpful, but for EBA, that's eligibility, benefits, and affordability. The task force will be asked, for example, this month, adopt a proposal. Finance and revenue, they're going to bring their initial kind of thinking about what a revenue structure would look like in Oregon. So you can just take a look at this and kind of, if there's a specific topic, Aida, to your point, that you really would like the more information on, I mean, this will give you a little bit idea of kind of where, what's coming to the task force. I do want to skip to, I think, Aida, your comments in general make me want to definitely pause on this slide. So Senator Manning, there is a Senate Bill 428. Everyone, we're happy to send out the link. You can look at the language of the bill and anything else that would be relevant for you all on OLS. Senator Manning and Representative Hayden and Representative Wilde, who are the 3 legislative members who serve on the full task force, have requested an extension. As Senator Manning has said publicly a number of times in the task force, and even said this when the bill was in the Senate Healthcare Committee on a public hearing, that recognizing the task force lost quite a bit of time because of COVID. And so the overall timeline has been compressed. The work of the task force has not been extended, and this bill would extend it essentially to February. So it would provide the task force another 6 to 7 months of work. And so what you can see here is, I think, if this bill were to be funded and to move its way through the entire legislature, and it would be voted both in the House and in the Senate, and then were to become law, the task force would see another 6-7 months of work, as well as continued support for staff. And I think a really large part of that continuation of work, and I definitely, Chair Glatebrooks and Vice Chair Santa weigh in here, the task force has had some conversation and will continue, is to have a really targeted, explicit community input process. What that looks like in a virtual world, because we will not be out of COVID entirely this summer. But I think that is something that the full task force really would like to think, and has asked staff to think about what could be done to have different community groups across the state, as well as other stakeholder groups, to actively participate in giving feedback on some preliminary or even the final design proposal. So that's what you'll see reflected here, is when we talk about stakeholder engagement in the summer and the fall. Those are 2 important activities that would happen. Again, the details would be fleshed out upon passage of the bill, but I want the CAC to know that I think, again, that is an important piece of conversation. Let me stop there and see if there's questions about the potential extension of the task force. And if either the chair or vice chair would like to offer any additional insights about the importance, I think, of really having some targeted stakeholder engagement, as well as working, and that goes to community organizations across the state, not just in the I-5 corridor, but really trying to hear from communities across Oregon.
I would just like to say, this is Glenn. I would like to say that I am working on inviting community-based organizations that have a foothold within their surrounding communities, representing diverse populations. And I'm waiting for I've invited a couple, so I'm waiting for for them to get back to me. And so we will, that is one way of how I anticipate involving community stakeholders, such that they can share also what they believe to be our important issues that the task force should consider. So that will start. I'm working with one organization that will probably take place in May. So I'll take a look at the schedule to see so that we can stay on the timeline. Thanks, Oliver.
Thank you.
You know, Oliver, I think just want to mention to Ada that if there are organizations who want to hear about the task force work, they can reach out to the task force or members of the task force and ask them to present or come to a discussion. That is going on. The vice chair of the task force, for example, Ed Junkins, has mentioned several times that he's been doing presentations for a variety of different community groups, especially in the Mid-Valley, Corvallis, Lebanon area. And so, you know, if any of you all are in touch with organizations in your community that would like to hear about the task force, and are willing to work with us on a virtual presentation, I think we're willing to do that.
I just wanted to give some input on some of the this is Ada again, on some of the organizations that I have been working with during the COVID. Has been a little difficult, trying to reach people by the, as they're working at home. And so the timeliness sometimes, doesn't work according to how they're working as they're, putting out fires in the communities. And then I'm finding a lot of them too, they're, waiting for their budgets and trying to regroup and, applying for funding. So it's just a lot that they're going through, as they're trying to work with communities. But I have put some feelers out. I have talked to a couple of groups, and I too am hoping, if it works with their schedules, that people can take the time on top of their horrendous schedules that they're already doing. And then coupled with some of the organizations that are downsizing, losing staff, losing funds, that's another hurdle. But I'm hoping to, keeping my fingers crossed, that we can get more involvement from the community.
Thanks, Ada. Oliver?
Yes,
you
that was I just wanted to walk through the timeline and prospective future timeline if the Senate Bill 428 were to be passed. Thank you, Chair.
Okay. Okay, John.
All right. Thanks, Glenn. So I have the pleasure of posing the first question for today's discussion. I think we now have 6 members in attendance. I saw Kevin a minute ago. He must have something that's taken him out of the room for the moment, but excited to get you all's feedback from the Finance and Revenue work group, who's dealing with how to set the single payer up from a business point of view to provide the benefits to the folks who are eligible for them. So here's the question. Right now, you're paying for healthcare in lots of different ways: premiums, co-pays, out-of-pocket expenses, etc. What Finance and Revenue has been focusing on is paying for healthcare from taxes. What kind of taxes would you support to fund a single-payer universal coverage system? So, is there anybody out there who wants to volunteer to go first, or do you want me to just call on folks? Volunteer.
I do have a question.
Sure.
When we're saying what kind of taxes, are we speaking in terms of like percentages or the of someone's taxable income, or are we talking about types of taxes like sales taxes or taxes on other items that we purchase, like the way gas is taxed or tobacco products?
Right. Both of those issues.
Right.
The tag has discussed income tax, payroll taxes, sales taxes, taxes on various vices, alcohol, other sorts of things. So part of this question is, each of those has pros and cons, and we're interested in the pros and cons that you all perceive each of those have. And then, I think what you're referring to is progressivity. A progressive tax puts more burden on those who have higher incomes and less burden than those on lower incomes. And each of the taxes I mentioned, depending on how it's implemented, can be more or less progressive. So, with that, Craig, more comments.
Thank you for the clarification. That helps a lot, actually.
Yeah.
And one of the things I always think about in terms of taxes is that we, as a society, as a nation, just have a knee-jerk reaction that any new or change to the tax that we are paying, unless we're clearly able to see that it's going down, we just react badly to it. And that's just something that I think is, maybe it's just a human thing, or maybe it's a US thing, but not only, I think what we want is, I personally would support a fairly progressive approach in terms of the burden being commensurate with one's ability to meet that burden. But and I say this realizing, I was like, oh yeah, do this very, very difficult thing. And I'll say it simply, but I know it's a very difficult thing, is, well, in what way do we make these taxes as, quote, painless as possible? So that the perceived burden is not exaggerated by our societal fear of taxes.
Okay. Thanks, Craig. Others? Ron, do you have comments?
Yes, thank you, John. I don't know. I don't know if it's time yet to soak the rich. I always wonder when that time will be, if it's come or not. But I do think that a progressive tax, not only on income, but on retained wealth would be appropriate. And I'm not sure what mechanisms there are to affect that, because there are some people with the moderate income and they have an extremely large retained wealth or holdings of various kinds, and then other people are making a lot of money and spending almost all that they make. So I guess the tax code could be engineered so that both of those kinds of wealth, both the cash flow and the balance sheet type of wealth, could be a target. But as Craig pointed out, there's a political cost and a social cost to pay for when you threaten people's income with taxes in any sort of way, especially when there's a perception that their hard-earned, quote unquote, money is going to go to people who are less deserving. And unfortunately, I think in this country, a lot of our American story, a lot of the mythology of America is that some people are perceived to be worth more than other people, and they're harder working than other people and more deserving than other people. So overcoming that, I think, is difficult when you're talking about who's going to pay the tax and how much and so forth. I was thinking about reading through some of the stuff that the TAG did recently, and there were some discussion about the social determinants of health. And, in the social determinants of health, we've got both a system design, in other words, our housing, our our roads, our food deserts, all of the things that we designed we built our world. And then we also, another component of social determinants of health is personal accountability and behavior, such as, people who take better care of themselves or have used more active transportation and so forth. And this all gets into very complex issues, because even the issue of, say, transportation, for example, does more affordable gasoline, does that enable more people of modest means to get to the healthcare provider, or does it discourage them from perhaps walking or riding a bicycle, if that's possible? So these kinds of issues of affecting behavior, I think that ties into the taxes. So when I say that I wish people of more means would pay more taxes, be a very progressive scheme, that's fraught with all kinds of other issues, especially in trying to develop an acceptable healthcare plan that will be enacted by the legislature and supported by the voters in the event of a challenge. So, but my bottom line would be go after the biggest money, and make it a system that we could kind of all buy into. That it's a system that will all be healthier, living in a more healthy way, not simply having more access to healthcare.
Thank you.
Thanks.
Others?
Hi there, this is Twee. Can you
Hi,
hear
Tweet.
me?
Yep.
Hi there. Good afternoon, everyone. I just want to start out by saying that I am not a tax expert or a tax system expert. I am a consumer. So with the tag presenting us this question, they're asking a group of people who don't know very much about the subject. What is Canada doing that is right? What other models are out there that is working, that can be presented to us as options? Do Canadians worry about paying for their health care every month when they receive a paycheck? What if they don't get a paycheck 1 month? How are they going to pay for it? So as a consumer, as a mom of 3, as a businesswoman, I am consumed daily with taking care of life. And most of folks, I think, in Oregon would be also. So whatever payment system that needs to be made so that we can have this universal health care for all Oregon, it has to be in such a way that it runs automatically for everyone, making lots of money, not making money, good time, hard times. What I would not like us to do is put more taxes on our properties, because that's going to adversely affect our senior who may have a home on a fixed income and unable to pay the exorbitant amount of tax that they have on their property. And every year that is increasing more and more. So I don't know all the possible tax system available that can be chosen from. I would like to be educated upon that. But we need to look at population that may be perceived to have accumulative wealth, but it's just their home. You cannot continue to put library tax, park tax, all these other tax on properties and think that, oh, these people accumulated this wealth, their property is increasing in value, but we got to think who owns these property. If it's your mom and dad on a fixed income, it's going to hurt lots of folks. So we have to look at maybe a variety of ways to pay for this system. I do not know all the options, but we have to look at it holistically. Transportation, not all people drive cars. I want to reduce my driving as much as possible, but I don't want to be burdened with property tax. Even when I had a choice of doing a health savings account, that takes money from my paycheck to fund that. Right now, I give up of my own choice and of my desire to serve, to be in the Air National Guard. So I give up 1 week in a month and 2 weeks a year to be in the Air National Guard to serve our country and state. However, they do offer very affordable health insurance for myself and my family. So I may not be paying a tax for it, but I am paying of my time. So we cannot continue using the standard tax system that we see out there and hope that it will work for this new adventure, this new opportunity that we are creating. So we have to look at it holistically, not just progressively, but innovatively. What can we do different that Canada didn't think of, or some of the other countries that have a more universal healthcare system? Come to us with options as consumer, then we can evaluate how that will fit us and give the tag feedback. But to ask consumer about tax system, I don't think they're going to get very good answer unless they give us option and guide us a bit. Okay. Thank you.
All right, thanks. Colleen, I see your picture's on. Do you have comments?
Sorry, I had to leave for a few moments, so I haven't heard everybody's input. But from my personal point of view, I would see it as something like Social Security and Medicare that we pay into through our payroll. And when we're in our earning years, for example, Social Security is divided between the individual and the employer. So I would like to see some kind of program like that. And like right now, I pay Medicare Part B out of my Social Security. Everybody does that who has Medicare Part B. I mean, these are easy ways that the burden would be shared, and I would assume that it would be progressive, so that as people have least ability to pay, they would pay the least. But I think there has to be some kind of a premium. I pay a lot of premiums right now. If I could consolidate it, I think I said last time, if it could be 10% of my income, I would be happy, because right now it's 30% of what I pay for everything. And if it's all covered, it makes sense to me to do it the same way we do things like Medicare and Social Security, to find a way to do that. And I'm positive that it would save employers and retirees like me. If we tied it to income tax, I'm in a bracket that I don't pay any income tax, so then I wouldn't pay any premium for my health insurance, and I don't think that's fair, because I do have, I have a pension and my Social Security. So we can't just have just an income tax, I don't think. I think it has to be something that is shared widely, but on ability to pay.
Thank you.
And I could pay something, is what I'm saying.
Okay. Thanks, Colleen. Ada.
Yes. Okay, so I would like to talk about the income tax. And I know that here in Oregon, we're one of the highest paying when it comes to income taxes across the states. So I would not want, the tax through income tax, but I would, as far as employer share, for taxes, I would agree to that, because most people who have an employer you know, they know what they want when it comes to their plans, and they're willing to pay for it, and they can afford to pay for it. As far as the progressive tax, that would also be according to a person's income. For example, I believe it's the local governments use the average median income that a person's ability to pay would be. So according to your income and, you know, what you can afford to pay, I believe the progressive tax should work well for that. And then also any corporate taxes that are there for the large corporations to be able to pay into that since they have a lot of employees as well too. So their share of putting in their fair taxes, because a lot of the corporations don't really pay a lot of taxes here in Oregon. Another way would be, I'd like to talk a little bit about the copays and the premiums. I see the costs are continuing to go up. I have a concern on that for people who may not have the ability to pay. So for example, I'm seeing a lot of employers even now, when they do hiring, they hire people, they may hire them under a contract. Their wages may be low. They may have no benefits. So I'm not in agreement with, you know, how employers are not offering the benefits that they used to for employees to have coverage for their benefits. I would say that, you know, we need to have an equal playing field on benefits that we're receiving as we're working for employers. Small businesses, there's an issue with those that, you know, if we're gonna, I know they're, you know, with what they can afford to pay, they're sort of at their limit of taxes. So for those small businesses as well, we need to, if there's going to be a tax, we need to limit it according to their ability to pay. And then speaking of copays, I'm for copays. I'm for premiums as long as the person can afford to pay for it, and that it is, you know, a person is able to pay according to their income limits. And then for the administrative costs, I would like to really pay close attention to that and maybe put a lot of emphasis on that the administrative costs need to be reduced, not high, but they need to be low enough. I would say 8 to 10%. I don't know if 20%, I mean, that may be a little high. So if we can keep administrative costs down, I think that would help us be able to afford better, affordable health care.
Okay, great. Kevin, are you with us? I've seen you on and off the screen. Looks like you've stepped away. Kevin? Well, maybe what we can do is when Kevin gets back in, we can have him comment. It looks like he's got a busy day going. Well, these are very good comments from the 5 of you who had input, and we'll share that with the financing and revenue group. And I'm sure they will be back as you know, their approach gets more specific with the sorts of overall schemes that they're thinking about. But you know, your comments were very helpful. I know, for example, Ron, the concept of retained wealth is interesting. You know, I can see that now that I've retired. I mean, quite frankly, I'm amazed what's happened with my retirement plans. I have quite the retained wealth that frankly I have done nothing to deserve. Stock market just keeps going up. You know, that's become a major portion of my wealth. You know, it seems we need to think about that. You know, the payroll tax, the Medicare and Social Security that Colleen mentioned, that is very broad-based. You know, I look back and I started paying Social Security tax when I was 18 years old, you know, and that's really broad-based. And so in many ways it's fair. So this was very helpful, really appreciate it. And unless anybody has any other comments, I'll pass it back to Glenn.
I did have a question in terms of I was making a basic assumption.
Sure.
Whatever financing or revenue stream to pay for the universal coverage, I was assuming that there would be multiple avenues, that there might be perhaps one of those additional taxes on something like alcohol, but smaller, because there also be a portion coming out of say payroll taxes and things like that. And one of the things that that struck me in terms of, if you will, messaging, the more we can show that this will save people money. Like, I think people who are having big chunks taken out of their paycheck right now would be more amenable if whatever chunk comes out in a tax is smaller than their previous premium, if you will. And that comes out of many people's take-home pay. And obviously not everybody would have the same level of savings, but I think that that is something that when we're talking about added expense to people, we also need to remember to mention, because I don't think we did here, that if this happens, you know, there will be savings for the consumer, not just the employers and overall.
Yeah.
All right, thank you.
Yeah, sure. Those are good comments, Craig. And I think you can assume that there's going to be multiple sources of funding. I mean, realize for this to succeed, we have to be successful at continuing to get substantial federal funds through Medicaid and Medicare, which, you know, are funded from federal income taxes and from federal payroll taxes, Social Security, Medicare, et cetera. And, you know, I think it's safe to say that there will likely be at least a couple of different sources of state tax that will be needed. And, you know, one thing that is important is you'd have to look at the administrative cost of you know, generating revenue. I mean, actually, one of my concerns, the administrative cost of getting revenue from copays is incredible. I mean, we're paying enormous amounts of money to collect $10 from a patient. You just wouldn't believe how expensive that is to do that. We're trying to take all of those things into consideration. So yeah, Craig, your comments are very much on track. So,
and I wanted to add, to John, to that, when you mentioned government, and I'm thinking through the COVID, I know we have many other resources that are coming out to the community through grants. So would a grant be another possibility other than, you know, the federal dollars that we could apply for grants to help pay for some of those costs? And as far as the administrative hurdles that we're dealing with now, I think our whole medical system needs to be completely reformed when we look at a lot of the antiquated systems that we're still using. And Twee mentioned something about being more innovative and, you know, trying to do things differently. I think perhaps we may want to look at, you know, the models and the different strategies and plans that we're developing, how we're used to operating, and maybe think and be more progressive in, you know, doing a total reform and, you know, doing things differently to reduce our costs, and maybe being more open to input from the community on what we could be doing versus what we are doing as we're working through the new normals, you know, through this COVID, to come up with better ideas of how we could be operating to reduce our costs for healthcare.
All right. Well, suffice it to say, I mean, we're talking about a system that will need billions. And so grants are usually millions. And while there may be opportunities for the single payer to get grants from foundations, it would likely be more in the vein of research that or other kinds of sorts of activities, and not as a an ongoing and predictable source of revenue. I just saw Kevin sit down and then he got up and left again.
John, just briefly, it's been mentioned that the copays, the premiums, out-of-pocket costs it's generally considered that those are greater costs than what a fair tax would be to the average health consumer or patient. I don't think that message, though, has been successfully delivered generally among the public, and I wonder if that might be part of what someone in the task force might be working on. I don't know. You probably know about that, but I think if people need to, they're scared of the word tax, but
Right.
they haven't clearly understood yet what most of us in this movement know, which is people would, not only this whole system would save money, but people would save money compared to what they're paying now.
That's right. Kevin, I see you in the room. Do you want to make some comments around taxes and the sorts of taxes you think a single payer should focus on? Can you unmute and make some comments for us about your sense of taxes?
So is the question whether we should support additional taxes for it, or should come out of current tax revenue? And, like, remember what we've done with Measure 110? We already had sort of a money collecting around there. It's just reappropriating it, or like, what are we talking about? A new tax across the top for all Oregon citizens, or what? Could you explain that a little bit?
I think we're at a very simple level at this point in time. What taxes would you think a single payer should focus on in order to provide a broad-based, fair, progressive source of revenue?
I would just like to check in here. We are running 15 minutes behind time, and we do have several more issues to discuss.
Yeah, sorry, Glenn, we are, but
I'll just say, yeah, I mean, I would
make a
definitely,
comment.
I mean, yeah, I would definitely support, I would definitely support some tax. I mean, my position is put everything into one big, huge kitty, public, commercial, private insurance and everything that funds it, and put it into one big pool. But yeah, but also then to tell our fellow citizens that we're going to need you to contribute if we want healthcare for everybody that meets people's needs, I guess. I mean,
Okay, that's interesting. One big kitty.
well, I think I've taken that from your ex-boss's idea, Mr. Kitzhaber, Dr. Kitzhaber,
Yeah.
a long time ago proposed something like that.
So let's wrap this up and go back over to Glenn. Thanks, Glenn.
You're welcome. Excuse me. Okay. Sorry. Let's advance to question number 2, which talks about high value care. I would just like to read to you the definition of high value care defined by a highly reputable source, which is the 2013 Institute of Medicine report. They define high value care as the best care for the patient with the optimal result for circumstances, delivered at the right price. So I'd be happy to repeat this definition at any time during our discussions at your request. So the question for you, for each of you, and I will take input from one of you at a time, and we'll call on you by name if you do not volunteer, so that we have every input, okay, from all. So the question is, based on your lived experience, including current past health insurance plans, coverage, patient services, and health outcomes, how would you describe high-value care in the context of providing and receiving healthcare benefits or services? Would you like for me to read that again?
I'm good.
I'm okay with
Um,
it.
Okay, so who would like to go first? Okay, I'll take it from the top, from those that are here. Tweet.
Hi there. Let me turn it on. High quality care. As a mom of 3, and I would like care to be in my neighborhood, accessible to me when I need the service. Children get sick, children has to be taken care of. Accessibility is highly valued in the quality of care for me. I am in eye care, so I took an oath to do no harm and do my very best to solve my patients' problems. So all doctors took a vote such. So qualification and how patient taken care of, at least initially, with regard to wellness care, should be accessible with an emphasis in looking at the patient holistically. For example, I am on a plant-based diet and it has solved a lot of my health problems. And so I would like a doctor that is sympathetic to my willingness to take care of my own health, changing my diet, changing my lifestyle, as well as my family in order to receive care. So I do not want to pick and choose a clinic based upon whether or not I have to pay a copay or not. I want to, as a consumer, receive care when I am in need. So that accessibility is just so very important to me. When a family member is sick, all you want them to do is to heal, to be better. And for some of my family members, they have like $7,000 deductible. I think they're going to think twice about calling an ambulance or just going, because they're going to have to pay after tax money to receive that care. And they're going to make a decision on healing themselves and their family and their loved one based upon that. That's why I'm here, because I hope the system will allow us to access the care that we need, be it holistic, naturopathic, nutrition, maybe an access to a gym, just to keep us all well versus emergency care. But when emergency care does happen, I do have trust in all the facility that's here in Portland, be it Providence, Legacies, Good Samaritan. But accessibility and cost, if we take that somehow out of the worry, I think that is very highly valuable for me.
Thank you, Tui, so much. Next. Okay, so then I would ask Colleen, will you please weigh in?
Yeah, this is a kind of a complicated subject, so we're all hesitant, I think. to get started on talking about it. High value care for me includes lots of choice. I have chronic conditions that I've had many practitioners write off. And those who take me seriously and get me are the ones I need to go to. I need lots of choice. And some of my doctors right now are 200 miles away, and because I live in a rural area, it would be nice to have more specialists in my area, but we just don't have very many. We have some, but not as many as we need. So access to folks who are further away would be great for me too. And I agree that the cost needs to be reasonable. You know, that is important to me, that the cost is reasonable, and that the service is available. But I need choice and availability to have high quality care.
Thank you. Kevin?
Yeah, can you hear me now?
Yes.
Yeah, I just, I think it was the eye doctor or somebody was talking about first do no harm. That's primarily important to me, particularly. I'm a person with behavioral health issues, and I assist, and I'm particularly in the area of do no harm around how we engage people who, like me, struggle with issues of psychosis. How we engage people to provide care for them sometimes ends up cauterizing their ability to trust us. It short circuits any emotional umbilical cord of safety that may happen sometimes with the trauma induced in some of our cares. I.e., I have a scar on my left shin where they slammed me into 5-point restraints on a wooden sided restraint bed that was bleeding for the 4 days I was actually in Providence Hospital in 2013. That's that kind of stuff is not high value care. I mean, it's built on something else, but really, that for me particularly, that's crucial. That's crucial. If it was up to me, I would remove every adage of anything that was violence against the patient to get them to conform with, whatever the course of treatment that's prescribed by the medical professionals.
Thank you, Kevin. Moving right along. Aida?
Yes. For me, the importance of high level from my lived experiences and through the health coverages and services and looking at the outcome for my community. What's important to me is cultural competency of the providers. There's a lack when you look at Oregon of the willingness for the attraction of cultural professionals to be able to treat the BIPOC communities. And because of that, the care is lacking for many of the BIPOC communities and the outcomes. So it's important to have people who have the lived experiences for the quality of care, those who are providing the care, that they have the lived experiences of those that they're treating, so that they will be able to understand and at least be educated and have the know-how to get a better outcome for those services provided. And also it's important to be able to have access within your surroundings. In particular for the BIPOC communities, many may not have access to transportation, or they may not be, mobile. They may have chronic conditions. So there's a lot of different issues that they may have to address in trying to get these services. And so for the social determinants of health, this area of social determinants of health is very broad. And I just want to make sure that as I'm speaking under this subject, that it is just not about the services for healthcare. It's also about the, I guess, the connections of other entities that work with the healthcare system, such as transportation. Um, you know, you have other, hurdles that deal with or systems that work with the medical profession. And so the lack of health professions, that's a key for me, is to make sure that there are enough. And that's something that I know they're working on right now through the legislature. Also being able to have the access. My concern basically with a lot of the systems that we have had, you can have a healthcare plan, but a person can say this is what we offer, but are you really receiving the benefit of it? And is it really providing a good outcome for you? That's what I'm looking for. And if it's not, then I'm going to look elsewhere. So for me, alternative services is a key for me, because I know sometimes when I may go to a physician's, they may not understand, what my needs are, what I'm looking for, and what outcomes I'm looking for. And it may not just be about medication. So those alternative services are good for me and for the communities for as far as outcomes. And then the other issue has to deal with when you're looking at the services. For example, I think someone mentioned earlier housing. Well, housing may be a service that your provider may provide some of the social services that go around with the healthcare services. Food may be another issue. So the education is another piece. You need to have education around keeping well. You need to have preventative services. So all those are important. I can go on forever. I mean, with a lot of issues dealing with the BIPOC community, it's an issue, within itself. It's a pretty broad area. So, but those are just a few of the areas that I would like to mention, that when you're looking for a transportation, affordable costs, you have to have affordable prescriptions, especially because I'm hearing that a lot of people cannot afford, when they have a plan, to get their prescriptions paid for. So the cost has to be there. The knowledge of the professional has to be there. The education has to be there. The prevention has to be there. And then the last thing I'd like to include is the oversight of the provider. There needs to be oversight with a goal and a plan of what is the objective and the goal. What is the end result that you're trying to provide, and what will the outcome be? Is it going to be a positive or a negative outcome? And I'm hoping that it will be a positive one for the healthcare plan if it's a high quality one. Thank you.
Thank you, Aida. Okay, Ron, we didn't hear from you yet. Would you like to weigh in?
Yes, thank you, Glenn. Just a second. Yeah, all of what I've heard here so far are very good aspects of high value. I think for me, I think of value for me is to maintain my health, whether I'm in some sort of treatment schedule, if I've got a particular chronic thing going on, or if I've suffered an injury or sickness that's going to be taken care of over long term. I think maintenance is important, and in that context, I think that perhaps support, what we would consider support staff, not support staff, but people involved in the medical delivery who are not necessarily physicians or the top licensed people in the field, but people who are therapists and nurses, aides, even support groups different kinds of workers in the system who are connected together, focused around the patient-centered model, such as a CCO model. And I think some of that can be counterintuitive in that maybe some of the most important people to the patient might not be the doctor, but might be an advocate or a therapist or a helper of some sort. And I think having those people in place for me would indicate a high value of benefit or service. Thank you.
Thank you, Ron. Okay, let's see. I don't think we heard from Craig yet.
Yeah, I will endeavor to be succinct. And the three things that come to my mind that I wanted to mention was the first, though not necessarily most important, is high quality care needs consistency. For people who have needed to use free clinics and such, consistency is almost impossible. You see different doctors every time you go in. Records, computers have made it easier for records to be kept better, but there's still often problems when you have these issues of consistency, of not being able to see the same doctor each time you need a visit. And that's something we take for granted at the level of insured people. And so hopefully that would be an assumption within the universal system. But I wanted to make sure that it gets mentioned because that's an issue for those of us who've had to use free clinics in the past, or even, I assume it still continues, that it's hard to get consistent care from something like a free clinic. And that's not part of high quality, is an inconsistency. The second thing I wanted to mention is that we focus a lot on physical wellness and prevention. I think if anything, the experiences of the last year show how close and fragile many of us are, and that mental wellness is something that we need to look after, and not just for people who have already been identified as having an issue, but for all of us as part of our general health approaches. Is like, how's your nutrition? How's your self-understanding, or however you want to address the mental health things in general, and help people who might be headed towards a crisis,